I am Dr. Nageshwar Reddy from the AIG Hospitals. COVID-19 has taken over our life, not only in the way how we practice medicine, but how we teach and learn medicine also. Over the last 1 week, we've had several webinars, seminars from different societies, from different doctors experienced this area. We at AIG thought that we should have someone who's really experienced in this, and fortunately for us, Professor Zhihua Ran has agreed to give this talk to us today. Professor Zhihua Ran is the director and professor of gastroenterology at the Shanghai Institute of Medical Sciences. He is not only a gastroenterologist, hepatologist, but also a molecular biologist. He's got huge experience with disease, in fact, probably the longest experience among all the gastroenterologists in the world now. He has given several talks, shows like this earlier in many countries all over the world. So we are glad he is with us. And co-moderating this session with me is Dr. Rupa Banerjee, Senior Consultant at the AIG Hospitals and Director of IBD Clinic. We'll now request Professor Zhihua Ran to give us his experience of treating patients with COVID-19 in China. Professor Zhihua Ran.
Thank you. Thank you for your kind introductions. It's my pleasure to join you. Yeah, it's my great pleasure to join this webinar meetings. So I will, focus on the lessons learned from China during the COVID-19 pandemic. Well, the COVID-19 is an emerging contagious disease that was first reported in last December in Wuhan, the capital city of Hubei province, China, and subsequently spread China and globally. On March 11th, World Health Organization declared the pandemic of COVID-19. The epidemic center had moved from Wuhan, China to Italy, Europe, and now to New York City and United States. So according to the data of Chinese CDC, since December 8th to the end of last year, there was totally 41 cases of unexplained pneumonia. Since the beginning of January, the number of patients identified has gradually increased with a significant outbreak in the later January and peaked in the early February. Then gradually declined now. By March 18th, 2020, no domestic new case reported. This is a landmark moment for us, which indicating we are entering into second stage of fighting against this disease. So by February 11th, 2020, a total of 44,672 cases were classified as confirmed cases of COVID-19. Most patients were aged between 30 to 79 years of old, and only 1% were less than was under 10 and between 10 to 19, and 3% were aged 18 years or older. Most cases were diagnosed in Hubei province, is about 75%, and most reported Wuhan-related exposures. The overall case fatality rate was 2.3%, but the elderly was most at risk from SARS coronavirus 2. Well, most cases were classified as mild, that means no pneumonia or mild pneumonia, and 14% were severe, which those patients were accompanied with dyspnea, hypoxia, etc., and 5% was incritical. That means a patient present multiple organ failure or dysfunction, etc. And at that time, about 3.8% of were healthcare personnel infected. Majority of them were in Wuhan, with some deaths reported However, this is not a major concern of COVID-19 spread. Rather, it appears that considerable transmission is occurring among close contacts. So, on admission, most patients had fever, cough, and a third of patients had shortness of breath. Other symptoms include headache, confusion, and diarrhea. At that time, in this cohort, diarrhea GI symptom was under 4%, and 19% patients present more than one symptoms, such as fever, cough, and shortness of breath in particular. Well, in Zhejiang province, a cohort outside of Wuhan, totally there was 11.4% of COVID-19 patients with GI symptoms. Compared with COVID-19 without GI symptoms, more patients were with GI symptoms had a severe or critical type and familiar clusterings, and had a significantly higher rate of fever, fatigue, shortness of breath, headache, and had more complications such as acute respiratory distress syndromes or liver injury, etc. Well, the chest CT is used for diagnosis of COVID-19 as an important complement to the swab test. Typical CT manifestations include ground glass opacity considerations, reticular pattern, as well as crater-paving patterns. Bilateral distribution of ground glass opacities with or without consideration or other typical CT findings in posterior or peripheral lens were the cardinal hallmark of COVID-19. The risk factors for mortality was old age, high sequential organ failure assessment scores, and as well as high D dimer at that time in Wuhan cohort. And apart from some common risk factors shared by ARDS and from ARDS to death, the risk factors for ARDS were dyspnea, lymphocytopenia, particularly CD4 lymphocyte count less than 250, for examples, and inflammatory related indices. So there are some features of pathological, features of lung biopsy in patients with COVID-19. We had conducted 2 patients, with early phase features of early phase. Conducted this in 2 patients underwent lobectomies for adenocarcinoma. You can find there was proteinous exudations, hyaline membrane was not prominent. And also, there's one case report of biopsy samples at autopsy. You can find there was diffuse alveolar damage pattern and interstitial fibrosis. The hyaline membrane was present. And about 10 days ago, the summary analysis of 29 autopsies had been announced during a news conference. They further confirmed the pathological finding of autopsy cases, and the virus particles could be visible in the lung tissues. There was a huge amount of mucus in the bronchs and alveolus. So based on our experience, therapeutical and triaging strategies for COVID-19 in fever clinics has been proposed, such as in febrile patients should have both chest CT and a respiratory viral test. If patients with normal chest CT scans and follows measure 1 interventions, if it is bacteria, a community acquired pneumonia, you can follow a measure 2. If it is virus, pneumonia, it should require, isolation and measure 3 to detect SARS coronavirus 2. And if patients present, dyspnea or hypoxia, measure 4 should be taken. Both measure 3 and measure 4, if patients detect positive for the virus, patients should be take measure 5, then transferred to designated hospital for further treatment. Well, so actually we had built 16 square cabin hospitals, totally 13,000 beds, and this is quite good because you have to isolate all those patients infected with the SARS coronavirus 2 infections. Well, there are some options for treatment, such as most patients was given oxygen therapy and antiviral treatment. And initially, because we don't know this is viral disease, some antibiotics also was taken. And some patients will receive intravenous immunoglobulin therapy and steroid therapy is about 19% to 27%, and also about 13% with non-invasive, mechanical ventilations, and 4% have invasive mechanical ventilations, and 9% with continuous renal replacement therapy, and 3 with ECMO treatment. So how to reduce the mortality of COVID-19 is of great challenge in clinically. So some groups had accumulated their experience to lower mortality. For examples, the experience from Jiangsu province, where there was totally 638 confirmed cases, no deaths was reported, and their experience was that early recognition those high risk critical ill patients by combining use these 4 components: the age, lymphocyte count, oxygen inhalations, and CT scan. And then they kept them under continuous close monitoring. And second one is early intervention guided by intensivists, by clinical experts, guided management treatment. And the last 3, it was integrated MDT personalized approach. So actually more than 300 clinical studies launched to treat SARS coronavirus 2. Those can be classified into, number 1, anti-RNA polymerase drugs such as Remdesivir, favipiravir. Those, anti-RNA polymerase drugs. The final results had not was not published yet, but it was published as promising. And also anti-HIV, antiviral, broad spectrum anti-malaria. The chloroquine is also with potential. Plasma therapy, cell therapy, as well as with some herb medicine, traditional Chinese medicine, and combined use antiviral treatment and other treatment. Only few of them will all designed RCT, such as Remdesivir in mild and in severe cases, 2 clinical trials, and the recombinant ACE2 in severe patients. So this clinical trial, the Rutinava had failed to show clinical efficacy. The chloroquine clinical trial is still ongoing. So this is the clinical studies, had published some days ago in New England Journal of Medicine. Overall, the mortality at 28 days was similar with similar serum viral load, so no clinical efficacy for Rutinava and the Rutinava clinical trials. Well, actually, chloroquine are recommended in China because more than 10 hospitals include in clinical trials. Chloroquine phosphate has potent activity against COVID-19 in some in vitro study, but we mainly prescribe chloroquine to those mild disease to prevent them to develop into severe case. And hydroxychloroquine is effective in Shanghai plan. It could reduce the ratio of severe and critical illness by, according to news conference. It was recommended by the guidelines for the prevention and diagnosis and treatment of pneumonia caused by COVID-19, 7th edition. And recently, an open-label, non-randomized clinical trials from France had also indicated the combination of hydroxychloroquine and azithromycin may be effective, but the sample size was limited, only 20 patients recruited in those non-randomized clinical trial, no control. So when you consider this data, you should be cautiously analysis. And finally, I go to the lessons we learned. It's all about the speed. The turning point of epidemic in China was completely locked down Wuhan and almost Hubei province in January 23rd this year. Because by the end of December last year, there was only 40 cases, and gradually was increased. Our doctors there had reported to local CDC. Our National Health Commission had sent 2 groups of experts to Wuhan since the end of last year. But unfortunately, they failed to find the evidence of human-to-human transmission at the beginning of this January. Then there was outbreak of COVID-19 in the middle, early January. That means the early warning system for acute contagious disease, which had been invested due to SARS 17 years ago, has not been effectuous. But after lockdown of Wuhan, there was, I think the lockdown Wuhan was right decision, and to provide the actual 3 to 4 days for the rest of China to take measures of prevention. We built 2 new hospitals within 9 days, these 2 Liangshan and Huashengshan hospitals. And we canceled all Chinese New Year celebrations and the prohibition of attendance at the school and work. And we dispatched more than 40,000 medical staff to Wuhan, as well as Hubei province for medical support. And there was massive mobilization of health and public health personnel, as well as military medical units. So we implement the joint prevention and control measures across the countries. All provinces and cities had adopted a first-level response to public emergency and structurally control community infection and strengthen community management. And we encourage citizens to wear masks in public when outside home. This is a very effective way, wearing the face masks. Also, we strengthen the protection of medical staff to avoid SARS-CoV-2 infections. Initially, more than 3,000 health care personnel infected in Hubei province, most of them in Wuhan, 40% in hospital and 60% in community. And after we strengthened the protection for the medical staff, 0 infected over those more than 40,000 dispatched healthcare professionals to Wuhan. So, in meantime, we reorganized the operation function of the hospital. For example, in GI unit, we reorganizing the activities of GI clinics, inpatient ward, and endoscopic centers. Quite a restrict, a screening policy or algorithm was recommended. So patients have to screen for those for COVID-19. Gastroenterologist was well protected when doing colonoscope. And many academic societies had published their guidance for management of patients. Those are the different guidance, and we update the diagnosis and treatment COVID-19 7th edition within 2 months time periods. And I mean, the bottleneck of diagnosis was the positive rate of RT-PCR for the swab samples at initial presentation was lower. It's only 30 to 16%. So it was in order to increase the diagnostic accuracy, we recommended to repeat swab testing and sampling at a lower respiratory tract and combine use RT-PCR with chest CT and RT-PCR with serum antibodies. You know, this, some study had found that virus could be detected in the stool. I mean, this is of clinical significance. It may indicate possible fecal-oral transmission route, and besides, coronavirus can persist in stool after its clearance in respiratory tract, which may have clinical importance. Yeah. The application of steroids in COVID-19 are controversial because we know already no definite benefit for steroids in SARS coronavirus as a group, and even found some harm, possible evidence of harm. And the use of virus may delay the viral clearance. However, in our studies, we found adequate dose, usually it's a low dose, and short-term use of steroids may be indicated for some clinical settings, patients with ARDS, etc. So finally, I would like to say, due to the rapid spread of pandemic of COVID-19, a global cooperation should be taken to fight against COVID-19 to control as possible, as soon as possible. So this is all for my sharing. We can have Q&A sessions.
Thank you, Dr. Zhihua Ran, for that excellent talk and overview. If you have time for one or two questions, we'll quickly go through that. We are getting a huge number of questions from audience all over the world. One common question is regarding the use of hydroxychloroquine in health personnel as prophylaxis. In China, are you using hydroxychloroquine for prophylaxis for doctors and nurses?
No, because it was the chloroquine was recommended in Chinese version of diagnosis and treatment in a booklet. The final result had not been published yet. It was only by the news conference, etc. The experts, the leader of experts and the authorities, they announced that chloroquine is effective by their experience, but we don't know the final result. It was recommended in the guidelines, in our Chinese guidelines. There are two forms. One is chloroquine chloride, and another is hydroxychloroquine. So with different dose. Usually we prescribe those chloroquine in mild disease patients to prevent them develop into severe case. So from the experts leader, they announced it's effective, and from the guidelines just published a few days ago, 2 days ago, it was also included in chloroquine. But we don't know the exact data, the compare groups, control groups, and the treatment groups. But as what recommended. But when prescribed chloroquine, cautious should be taken. But if it may have some effects on QT interval. So hydroxychloroquine and azithromycin both have the effects on QT interval, may prolong the QT interval. So it should be cautious in clinical setting. Yeah.
What is happening is in India we are now in lockdown, and there are indications that over the next few weeks it may be slowly eased out. So Zhihua, I would like to know from you, what is your recommendation and what you did in China regarding mass screening? Because so far in India, we are primarily doing screening for people who have a history of travel or are symptomatic. Do you think mass screening would have some help?
Yeah, mask is beneficial for all the subjects. You know, the lockdown, the day of lockdown Wuhan, just one day before the eve of Chinese New Year, we're in holiday. This real the good side of the coin. You know, so for almost 2 weeks, 100% of Chinese stay at home. They just keep at home to prevent, to minimize the public exposures. So after 2 weeks of Spring Festival and 1 week prolonged on the holidays, we still not yet recover to work. We had additional 1 week
And
for
how was
stay at
lockdown
home.
eased there? I mean, what was done in China for easing the lockdown? Was it sudden one day lockdown gone, or slowly it was eased by phase by phase?
No, everyone, after lockdown, the rest of China, Chinese, also stay at home. We try minimize the public exposure. When we outside home, we wear the face mask. So this is different culture between the East and the West. And in the East, in particular in East Asia, in China, we wear face masks for almost 3 months now. We still wear the face mask until the 2 cycle of incubation time for the last domestic cases reported. I had tell you the last day for zero domestic new cases is March 18th. That means after 2 incubation time, one incubation time is 2 weeks, 14 days. So we will, after 28 days, we have the chance to take off the face masks.
Professor
This
Zhihua,
is quite direct. And this is very direct. You're gone.
Yeah. So what is the incidence of reinfection? Is there a chance of reinfection? So once somebody has the infection, is he completely immune, or can he get another infection with this virus?
Yeah, this is quite an interesting phenomenon. Initially, we didn't aware of that, but afterwards, I think since the middle of February, because some patients gradually recover, they was discharged, but after discharge, they found the swab test re-positive. So these patients will follow tight, isolation and medical report monitoring. In Shanghai, we use very more restricted, standard for discharge. For the standard for discharge was 2 consecutive swab tests was normal, and body temperature returned to normal for consecutive 3 days, and there's marked improvement of respiratory syndrome and marked improvement of CT scanning. But in Shanghai, we add fecal swab test negative. So this patient can finally discharge. So in Shanghai, I don't know whether they also got the re-positive case, but in Guangzhou and Wuhan, other provinces, they have reported patients' serum conversion become positive. So what is significance of clinical significance? We still don't know, but we tightly monitor these patients. So for those patients who discharge, we ask them to continue 2 weeks for monitoring.
Zhihua, this is for patients. We have a lot of inflammatory bowel disease patients, cancer patients, all on immunosuppressives, chemotherapy. What would your recommendations be for these patients? Should we continue? Should we withhold at this current time? What if there is a relapse? If you could just tell us a few lines on that.
Yeah, so we also, had already had a discussion during I1IB webinar. We had published the recommendation, the RANT recommendation to Gastro last week, and there are several recommendations and also posted on the website of IIP website. And in principle, we think protect patients from SARS-CoV-2 infection is most important. For those patients, IPD patients, for example, if they are in remission, just keep on the previous current treatment. We are not recommended to reduce the dose or stop biologic treatment. Protection is most important. For those active disease, we try to encourage patients to reduce the hospital visits in order to reduce the chances to get infected. Such as in China, we recommend patients, if possible, from infliximab infusion switch to adalimumab, subcutaneous, so they can reduce the chance of hospital visits. So for the rest of medications, apart from steroids, we high dose of steroids, we recommend a physician try to take in a high dose. For the rest of the immunosuppressants, enzacycline, methotrexate, biologics, anti-TNF, Vido, etc., they can keep on going. Yeah, this in principle.
So, Professor Ran, there are a lot of questions on use of N95 mask because supply is not too much here, short supply. Some people recommend that they can be reused after putting it in a microwave or heating for a certain degree. So, in China, is there a recommendation for this, or it's only single use?
No, for the publics, for the general populations, just use the surgical, mask is efficient. N95 is only for medical staff. Yeah. For the residents, there's no need for them to wear the specialized mask. It's only for medical staff. Yes. And just try to be sure to protect yourself, your colleagues, because medical staff should be protected. If one medical staff got infected, maybe one team will be quarantined. So who will care our patients? So before, at the initial stage, there was, as I shown you, about 3.8% of medical staff got infected, because at the time, the physician don't know this is highly contagious disease, so they got infected. But for physicians working at fever clinic or department of emergency, no physicians got infected, because at daytime they every day wear the masks. For the internal medicine, for us, we usually don't wear the face masks. So a lot of physicians got infected is from internal medicine or department of surgery, not fever clinic. This is the sense to protect yourself. This is very important. After lockdown Wuhan, we dispatched more than 40, actually it's near 50,000 medical staff. No one get infected because they were well protected. If you look at the number of medical staff get infected in Spain and Italy, it's a lesson, So just tell your India colleagues, protect yourself. This is good for your patients, for your family, and for your children.
I think this is a very important information that Professor Zhihua Ran has given us, that if you protect yourself properly, of course N95 cannot be reused, nobody recommends it should be reused. If you protect yourself, and it is clearly shown by the Wuhan experiment, where the first initial part, about 3.8% of medical personnel got infected, and in the second part, when 40,000 medical personnel came in, not a single person was infected, which is, I think, a very clear evidence that proper protection will help medical personnel. I think Professor Zhihua Ran, we'd like to thank you very much for coming on this webinar, for giving us so much valuable information from your personal experience, from this long experience you had. All of us here, not only in India, but surrounding countries, are extremely thankful to you for coming and addressing us. Thank you very much.
Thank you.
Thank you for your invitation. Yeah, thank you.
Thank you, and be safe.
Thank you,
Thank you.
Professor.
Yeah, bye-bye.
Bye.
Bye.
So we just conclude this webinar with Professor Zhihua Ran, who is one of the pioneers in this problem in the world. In fact, he was one of the first to start treatment in these cases, and is clearly summarized the clinical picture, the investigative profile, and how a combination of RT-PCR, CT scan, and antibody will give you 100% results, whereas doing only one of them may be only 70-80% sensitive or specific. So this is again important information. He told us that prophylactic hydroxychloroquine is not used in China, although they're doing a large trial with hydroxychloroquine and azithromycin. So right now, no specific drug except plasma, which is used in patients who are very sick. And he's also talked about steroid use. I think this is a very important point. He's advocated early steroid use. This has been a controversial point, but he says early steroid use is going to be helpful in patients who are getting sick, not after they get very sick. And finally, of course, he's told us about the use of various protective equipment, and also how medical personnel can get protected by using this. We're extremely thankful to him, and like to thank all of you for seeing this program.